Hello, good evening and good day to everyone. It's great to be once again back here with all of you. Thank you so much for joining us tonight. And as you can see, we have our special expert right here. And I think that most of you at least are already familiar. This is Dr. Uliana Dorofeyeva, and it's great and amazing to have you back. As always, you bring very, very interesting sessions, and we are always happy to have you back as our presenter. So hello, Dr. Uliana. How are you feeling tonight? Hope all is well.
Hi, Carolina. Good evening, good afternoon, everyone. Thank you for joining us tonight. And for me, as always, it's my special pleasure to be here with you and to stay here another 1 hour or two. We will see how this will go, how many questions we will have, because this is really a special topic. And I love that topic, and I have a lot to share with you, of course.
And we are very excited. And yes, I can definitely confirm Dr. Uliana has mentioned many, many times before, this is one of her favorite topics. So I'm very happy that we were able to make it happen and to give you this chance to of course, explain all about ovarian aging and oocyte quality and, of course, women's age. And that's why we are here. And of course, we will start with Dr. Uliana's presentation on this topic, but afterwards, your favorite part, Q&A session. So remember, you can type the questions in the chat section and Dr. Uliana will answer them for you right after the presentation, okay? And let's not waste any more time. Let's go ahead with the topic. This is definitely a very, very interesting topic. So I think everyone is ready to start with the presentation, okay, Dr. Uliana?
Yes, absolutely ready to start.
Perfect. Let's go ahead then.
So, dear our patients, we are going to talk about ovarian aging, oocyte quality, and woman age. Before we start, I would like to just to present those goals which our medical team and our coordinators and all people involved into communication with our patients and into the treatment are sharing. And our goals is to achieve a pregnancy as soon as possible. And this is true that patients are referring to us in their different time and different age. And very often for Ukraine as a country being legally providing oocyte donation and surrogacy, this is not a country where patients are contacting us with the initial infertility and those patients who never tried their IVF. But very often these are patients with their negative attempts in the past who experienced a lot of IVF treatment already, and they are looking for the second opinion or the best option or the alternative options for the treatment, and we will talk a lot about those. Another goal which we created for all our team, this is to maximize the success rate for the first and initial cycle together with us for each patient. Again, you will refer to the fact that you have already so many negative attempts and what we will do differently in order to maximize the success and to get the treatment done within and successfully done within the first attempt. However, in Ukraine, being a country with many unique treatment options legally available and also many experimental options being available, and after we are learning in details all your medical history and all records, and we are offering those screening regimens which quite often were not recommended before, for example, as immune treatment, as individual window of implantation, as key receptors, as many, many others, and also treatments, including extremely successful oocyte donation alternatives as pronuclear mitochondrial transfer, surrogacy, any kind of treatment. So by combining all this and after completing full screening, we really are getting to very successful IVF treatment. Another goal is to reduce multiple pregnancy and guarantee safety in IVF. This is crucial, of course, and to help as many patients as possible, including the fact that we, being in Ukraine, may reduce the costs by understanding the low limits. We may offer those treatments which are available in Ukraine, and we may use the most effective techniques which we are practicing right now. If we are talking about our biological clock, so even now we are spending our follicles, we are producing our oocytes, we are depending on which level of FSH we have. Right now, we are involving one or several follicles to be growing and to recruit the oocyte inside of the ovary, but also some of our cells are getting into the process of apoptosis. And for any woman who decided to have a goal of getting the fertility treatment done, timing should be crucial, independently in which age you are, but specifically in you are in your age over 35 and higher. So to understand the time and why it is so crucial, and also what we are losing by wasting our time or postponing our IVF treatment, we need to understand this graph. And I will stop here for a bit longer in order to explain this better. So the number of antral follicles which we are going to spend during all our entire life is dedicated, is settled for the fetus, for the female fetus during her antenatal development. So since we are 7 months inside of the uterus of our mother's wombs, we already have our total number of resource of our antral follicles, which we are going to use during all our entire life. And after the first meiotic arrest, once we are born with the certain number of antral follicles, which is around 2 million. And until the period of puberty, until the first menstruation, when we started it, we have a second meiotic arrest, and we are left with about 4,100 to 5,100 antral follicles in both of our ovaries. And since we are starting our menstrual cycle, depending in which age we are, the younger we are, the higher number of antral follicles which are recruited in our every and next menstrual cycle. So if we are in our young age, the total number of follicles is about 20 in every ovary. And if we are getting older, the total number of follicles are getting lower. However, every cycle, new cohort of the oocyte is being recruited and have a potential to grow. However, during our entire life of the ovulation and having menstruations, we have between 400 to 500 ovulation cycles. And if the hypophysis is producing a certain dose of FSH, and this certain small dose of FSH is recruiting only one follicle, which is growing up to being dominant follicle and is able to ovulate and produce the oocyte inside of this. So all others on the stages they are just getting into the process of atresia. And atresia, this is their death. So we will not be able to use any of those follicles in any time in our future. Meaning, we started our cycle, we recruited certain number of follicles depending on which age we are, depending on how much follicular stimulated hormones we received. So many follicles were grown in order to respond to the FSH and produce oocyte. If they produced oocyte, we are able to collect this oocyte and we can freeze this oocyte, we can fertilize this oocyte, we can use this for the future use. If we haven't given additional FSH dosage, so they were not recruited, however, still they just disappeared. That's why this is so important to understand this process for women who are in their older maternal age, because they still produce some of their cohort of the follicles. Every cycle they are given small amount, but still they can recruit certain amount of the follicles. So this is so important to use this small amount in order either to keep it frozen or to use for the IVF treatment. So 99.9, even I would say more, of our follicles are going to the process of atresia. So they are lost and we have no chances to use them during our entire life. And there are many anti-aging therapies right now, which we are all successfully using. We all like to look younger. Very often we keep the healthy lifestyle, and this is also important, and we will talk about this. However, there is no chances to anyhow implement the quality and the safety for the ovary. We can only still the timing, like anti-aging therapies for the ovaries, they are existing, and we may talk about ovarian rejuvenation, which is still experimental method, but still we are using this very successful. And there is a certain cohort of the patients for whom we would recommend to do this method, but it should be done prior to the treatment. So as soon as you decided to have your treatment done, we can improve the number and the quality of the received oocytes by performing ovarian rejuvenation technique. However, this is not long-lasting procedure, and this will not last forever. Of course, we need to understand this. And this is true that the average age for the first delivery in the world is increasing, and every decade age of women delivering their first baby increasing for 2 years. And if we will keep the tendency, so we need, as being responsible fertility doctors and understanding this trend, we need to offer the effective treatment for those women who are coming, being in their older and older maternal age for us, but they are still expecting successful treatment and they believe that they will get into this. So we have periods which we dividing into the optimal fertility, declining fertility, end of the fertility, premenopausal and menopausal age. So this is a timing when we are producing less and less oocytes. To understand full IVF cycle, and it is absolutely different in different ages of our patient. However, once we start our stimulation, we have ovarian stimulation and oocyte retrieval. There are certain demands to the IVF stimulation cycle. The most important is to guarantee safety, but also to receive optimal number and the quality of the oocytes, which after the fertilization and embryo cultivation, we will select the best quality embryos in order to transfer into the uterus to be expected with, to end up with the clinical pregnancy, if possible, to freeze additional embryos for the future use. If we are talking about patients in their advanced maternal age, so our aim would be to select such stimulation protocol to produce at least one euploid embryo to have the possibility to be implanted. And if we are talking about ideal stimulation protocol and gold standards in stimulation, again, for different ages of the patients, the rules would be different. If we are talking about young population of the normogonadotropic women, so we know that the best stimulation medication will be recombinant FSH, which will lead us into the sufficient follicular development and optimal number of oocytes retrieved. If we are talking about the patient population of over 35 years old, in addition to recombinant FSH, we need to add LH. And this should be added since the first day of the stimulation cycle, as we need to work already with the receptors. So we need to work with both types of the receptors, LH and FSH, in order to recruit more follicles and to get higher quality of the retrieved oocytes. In any time, in any age of the patient, we need fully control a cycle to achieve an individualized number of oocytes with optimal amount of medications used and with no complications for the patient. Again, based on the profile of the patient, this can be absolutely different, and you need to discuss this specifically with your treating physician, and depending on your hormonal profile and the antral follicle count, IMH, which you are having, previous outcomes, previous medications which were used, stimulation protocols which were offered by the doctors, but still there are some rules. For example, the maximum effective dose which we recommend to be used in any case of any age of the patient would be 300 international units. But for lower responders, even less dosage of medication is considered to be more effective, because anyhow we have a certain yield of the follicles to be recruited, and with increasing the dosage, not obviously that we will increase the number of the recruited follicles. Oocyte number and used oocytes and embryo rate are strongly correlated, meaning we would receive, if we would receive more oocytes, there is higher probability to get more number of blastocysts in any patient age, and also higher probability to receive euploid embryos. And by this, we will increase our cumulative or multiple pregnancy rate per one cycle. But again, for older patients, the aim would be, as I said, to receive at least one euploid embryo. And poor responders, we call poor responders by those patients for whom we received that less than 3 oocytes in their previous stimulated cycle, or these are patients with less than IMH less than 0.5. So the best protocol should be offered in order to receive at least one euploid embryo, and this best protocol could include Shanghai protocol, double stimulation, letrozole in the stimulated cycle, estradiol pretreatment. There are many options which are available. However, they all need to be individualized. If we are talking about the possibility and probability for you in any age to produce your healthy oocyte, so probably all you know that the quality and quantity of the oocytes which we may produce decreasing with the age. And we may do a lot, and we may try different methods and techniques in order to produce as many as possible and as highest quality as possible your oocytes. However, probably there would be a day when someone, some physician in some location will offer you oocyte donation as an alternative to get your successful treatment done. And this is right now, by now, this is the best alternative widely available and giving the success rate between 50 to 60%, even in good places as our clinic. We never had less than 60% clinical pregnancy rate for oocyte donation treatment, even with very poor sperm quality. So this is independently in which age you are, this is very successful and right treatment. Which mechanisms, however, we need to understand those mechanisms and how we can overcome them and make sure that we cover the issues which we may do for your oocytes which you are producing, even if we have less of their quality, we have less of their quantity. So oxidative stress and changes in the mitochondrial activity as mitochondrial dysfunction and endoplasmic reticulum dysfunction is bringing us, and also issues with the calcium channels and the level of the calcium inside of the cell are bringing us together. All this issue are bringing us to the poorer embryo development and poorer quality of the embryo, which is correlated with the oocyte quality. So there are treatment strategies as calcium ionophore, which we are using for advanced maternal age oocytes to activate this cell in order to be more healthy and to get better embryo development. we can overcome oxidative stress by giving supplements, and we will talk a little bit more about those. There is always a question, how long should we take the supplements in order to be effective, and how this works. So here you can see the graphs explaining how long the primordial follicle, how long time it takes for the primordial follicle to grow into the small antral, which will be already sensitive to FSH and which will be able to produce the oocyte inside of the follicle. So usually altogether this is over 200 days. So these 200 days since today, you will produce your new dominant follicle, which will produce the oocyte inside. And this is ongoing process, as the same process we have for our mens. However, they are getting their sperm renewed every third day. And this is not the same for women. So we are producing new cohort, and this is constant process. However, it happens only once in every 200 days, but it's constant. So you get a new pool every day. However, it started almost more than 3 months ago. And this is very important also for patients in their old maternal age, that we have right level of androgens. We were talking already about LH. It is important for older maternal age, but also androgens, because androgens, they are helping FSH to connect with the receptors. And androgens are helping in the luteal phase for our follicles, for the new cohort, to be prepared for the new cycle. That's why some of the supplements are dehydroepiandrosterone sulfate, which is DHA, which we very common used by our patients. However, we need to discuss about this as about all other supplements, because there is quite not confirmed data about the evidence to be used by the patients. Still, many patients and many clinicians would recommend supplements and also antioxidants for the treatment or prior to the treatment for many of the patients. However, there is limited evidence suggesting to take these antioxidants or supplements for improving fertility. And the trials have explored this area with various results. Personally, I'm not against that patients are getting supplements. However, I'm always asking patients to let your physician know what you are getting, how many milligrams, how many pills per day, how long you're getting this, because side effects of overdoses of these medications are also sometimes crucial. So this is very important that your physician will know and correct in the average dosage or in the safety treating dosage, those medications which are not crucial like FSH and direct stimulation medications, but also others which are playing the role in your treatment cycle and also involving your general somatic status. If we are talking about clinicians, it's a little bit different for the patients. However, I would like to show you this diagram regarding what we consider as being the best evidence in medicine and why we are recommending something and we would like not to communicate or not to comment for something else. So there is missing friend advice or being read in the forum, etc. But this will be the very downline. But what we consider as being true based on high evidence, this is at least clinical research or trials or comprehensive systematic review or meta-analysis. So all this information does not confirm that the supplements which we are recommending for improving fertility or rejuvenate the process of producing the oocyte as being as maximum effective. As I said, folic acid, this is something what is confirmed. All the others, we as a clinician, we are not fully against but we need to understand that there is not much evidence for this. So let's talk more about science right now, what is already an evidence. However, this methodology about which we are going to talk right now, it's still experimental. However, we all know that IVF treatment is less than 50 years used worldwide right now. And before 50 years ago, we had no experience to use any kind of IVF. And if patient faced infertility, there was no treatment available. So right now, we all are using IVF treatment and we are very successful in this. Those topics which we are going to talk right now, they are still experimental, but our scientific team and clinical team believe that this is the future and this is great alternative for those patients who tried already general approach, different stimulation regimens, who produce their own oocytes, but they are not ready for this alternative as full oocyte donation. So what is controlling oocyte quality? We were mentioning this about, but these are small organelles named mitochondria, which are providing the energy for the cells. And if we are getting less energy for the cell, we are getting problems in the embryo development, in fertilization. So if there is no battery, there is no work and no further growth. So, and the age-related changes in oocyte mitochondria, we may see that the number of mitochondria are getting down. They are much less in the aged oocytes. Also, these mitochondria are getting morphological changes, and the most important, that inside of the mitochondrial DNA, because they also keep some part, small part of our genetic materials, we are getting deletions. And by all this, we have altered function of the cell in general, and this can be blocked fertilization and block of the further development of the embryo. So by mitochondrial dysfunction, we are getting into the lower IVF success rate, lower fertilization, and higher aneuploidy rates for the embryos. So the solution, as we mentioned before, this is a conventional oocyte donation. Once we got a healthy, mature oocyte from the donor, fertilized with the husband's sperm and transferred into the uterus of the intended mother. The causes of the poor oocyte quality, except the maternal age, is also genetic factor, endometriosis, and some other factors. And the alternatives which we are going to talk, this is the fact that if we may solve the issue with the mitochondrial dysfunction, we can offer to the patient, using their nuclear DNA and their nucleus of the embryo, which consists the most part, more than 99.9% of the genetic material, to have genetically related baby. And oocyte donation looks easy alternative from the perspective of the physician, because we really are happy once patient is deciding for oocyte donation, because we know that the probability of getting pregnant is very high for this patient. However, still, if there is a possibility, patient has a right to carry her genetic material and their ovum genes during the pregnancy. There are psychological and ethical different thoughts for the patients before they will accept full oocyte donation treatment. So they also need to be considered. So how this works? We are offering two programs as a spindle transfer or pronuclear transfer to be able for these patients to keep their genetic material. But to understand the process, let's talk what is the spindle. Spindle is the small organelle inside of the cell, which is responsible for division of the genetic potential of the oocyte. So this is the organelle which is responsible for mitosis, so-called. So if the spindle is fine and the quality is nice, so mitosis will be provided fully and nicely, and we will get a zygote. If we are getting zygote, this zygote has a potential to grow for the 4-cell embryo, 8-cell embryo, morula, and further to the blastocyst. Only special software can detect the spindle that it is available inside of the oocyte. And why we are detecting the spindle? Because for advanced maternal age patients, some of the oocytes, even if they are mature, they have nice cytoplasma, they have no organelles included into the cell, they have polar bodies, so all factors which we may consider this oocyte to be morphologically right. However, once we are checking the spindle, oocyte may be empty. So meaning there is no potential for this oocyte to be fertilized. And mostly these oocytes are staying even after ICSI done for them, they are staying unfertilized. So the spindle transfer, this is the technique when we are offered the replacement of the entire cytoplasm of the poor quality of the oocyte. So if you don't see the spindle from the patient oocyte in the patient oocyte, we are getting this cytoplasm with the spindle and with the healthy mitochondria, and we are putting them inside of the maternal egg and giving a potential for this nucleus, which is inside of the oocyte, to develop right and to be fertilized correctly and give the potential for the blastocyst creation with the further implantation. So this is, you may see on the scheme how this works, meaning the spindle is removed and put it into the donor oocyte, from the donor oocyte into the maternal oocyte, and then reconstructed zygote is fertilized. And we may see pronuclear stage zygote with the further development to the blastocyst. And the advantage of the spindle transfers is the following, that we are giving to the families affected with the serious mitochondrial diseases, but also patients in their advanced maternal age to create healthy embryos and give them the potential to be carried out as a pregnancy by their patients. Mitochondrial donation is very commonly needed in some countries where there is a high prevalence of the mitochondrial diseases, and there is comparably less mechanical and morphological damage to those embryos, but it needs to be done in the right laboratory with the highly skilled embryologist, absolutely. And pronuclear transfer is very similar to the process which we just described. However, for pronuclear transfer, we fertilize both oocyte from the donor and oocyte from the patient by the husband's sperm. And once we received zygotes, we exchanging the pronucleus inside of the zygote. So we are removing pronuclei from the maternal oocyte and putting that pronuclei into the healthy oocyte with the young mitochondria inside of the donor oocyte, and with the further development as we presented below. So this is another just schematic picture. And there is no risk for fertilization because the transfer is already done between the zygotes. There is better blastocyst outcome. Again, it gives a potential for patients with the mitochondrial diseases to have a healthy child, and technique and mechanical micromanipulation requesting experience and special cultivation method during the micromanipulation. Another issue, this is related to the genetic abnormalities for the patients and how it is connected with the patient age. You may see, and this is great graph, which we are showing to many of our patients just during the initial consultation when we are discussing the probability for them of getting pregnant. Because we need to be clear with the patient, and we educate our patients a lot. Many of them are well educated already, and we really appreciate the fact that they understand what we are going to do, what we are talking about, and how we together as a team making our goal to getting pregnant. However, this is something what we cannot overcome. Even 30% of oocytes coming from oocyte donors are already uneuploid. And this is the fact which we all probably know, that even if we are young and healthy and we are trying to conceive, we are not conceiving from the just having a first sexual intercourse. And sometimes it takes several months and sometimes up to 1 year in order to getting pregnant. And this is mostly related to the oocyte quality. And this is important to remember. I would like you to remember these figures because we are going to talk about them also later. However, if we are talking about patient oocyte and patient embryos, so we need to see that if we are over 35 years old, 50% of those embryos which we will receive, and this is a challenge sometimes to receive blastocysts, and we are receiving 1 or 2 blastocysts, and we are very happy for that patient. However, if we would do pre-implantation genetic testing and we will check the rate of the healthy embryos, we will understand that this rate is lower, and sometimes we have 0 euploid embryos, and this is really cancelled embryo transfer, and this is hard to explain to the patients because we were hoping for absolutely different result. So we need to consider this once we are planning our treatment for any patient in their reproductive age. But this is great that we have an opportunity to check this, and we are not giving to the patient false expectation of transferring non-healthy embryos into the uterus and giving them a risk of implanting those non-healthy embryos, and then, you know, overcome these issues with the pregnancy, which is not right. So options which we are offering, this is oocyte NGS testing. So we may check if this oocyte is healthy and if the oocyte is going to produce as healthy embryo, and also PGTA or NGS testing of the embryos, which is specifically recommended for the patients in their advanced maternal age. Another factors which are not connected to the embryo quality already, however, they are connected to the implantation potential. These are like thyroid function, like immune status of the patient, like individual window of implantation, and embryo endometrial crosstalks. These are a lot of points which needs to be confirmed and which we are also checking for all our patients in order to maximize their chances to getting pregnant. Just a few words regarding Ukraine. So right now we have over 60 private IVF centers in Ukraine. Many of them are offering treatments for international patients. However, you need to be very careful in order when selecting the clinic. I would really recommend to talk to the team to get as much information as possible. Also get advices of your friends and colleagues also through Egg Donation Friends, because having so many clinics, you can get into just a nice picture online, however, not to be surprised after that. However, most of the clinics, they are really reliable and with very high efficiency and high quality of the communication. What is important to say that we have legal oocyte donation and surrogacy, also export of biological materials. However, we are going to have another webinar later this week, and we will talk about legislation in Ukraine. So this is not a lot to say during this webinar. However, I would like to mention that even if you are located somewhere outside Ukraine and you have no options to travel right now, however, in your country, oocyte donation is legal, you can ask your clinic or you can ask us, because we are sending a lot of biological materials all over the globe, and you can see in that map in green, these are locations to where we are sending our oocyte, vitrified donor oocyte, and you may avoid traveling to Ukraine, but you can get your egg donation treatment done in your country if this is legal and if we have option to do this. However, this is only for conventional oocyte donation, not for mitochondrial transfer, not for surrogacy, not for any kind of these like ovarian rejuvenation, etc. For single women, we have an option of offering also sperm donors and their samples, and even embryo donation if this is something what is recommended by clinician for you as a couple, as well as surrogacy. Also, I would like to mention that you have a right to transport your biological materials between the clinics, between the countries. You can store your materials in any destination you feel this is right to do. And this transportation is always done under the condition of international rules and safety. So you can ask also us if you need this help in that. Very important to say that, and I like this scientific paper coming from Israel. And Israel, probably you know, this is the only country which covers all IVF treatment being absolutely non-paid until family has 3 children in their family. So they published a paper of live birth rates after unlimited free IVF. And they checked the couples during within the period of 4 years. So 95.9% of the couples conceived if they had unlimited chances, meaning they waited 0 time. As soon as they have opportunity to start their cycle, they started their cycle, and they used as many of their biological materials as they may produce. Also, Israel is the country where the average number of stimulations per patient is 18, which is, I would say, extremely high. However, also we can see the results that if you will keep using your option for IVF treatment and you will keep trying, still there is a possibility and high probability of getting pregnant and getting a successful delivery, because they were putting also not only information about clinical pregnancy, but also live birth rate. And another data coming from UK, you may see that within 9 IVF cycles, even with those own oocytes, which is the graph in blue, own oocytes between the age of 40 to 42, we are getting to as maximum as 25 up to 30% clinical pregnancy, cumulative clinical pregnancy rate, and it's not going higher. But with own oocytes before the age of 40, and specifically with donor oocytes, there is an increase. And with donor oocytes, it's coming also closer to 100% if we repeat and repeat our IVF cycles. So just a few more minutes regarding the genetically certified oocyte technology and why we decided to offer this. So you may see the image of donor oocyte under the how we do the morphological evaluation. So this is high performance of the microscope, and we are checking in details all the morphological features of the oocyte, including spindle. But also we do, after we did this clinical trial and we did the polar body biopsy for around up to like 1,978 oocytes, and number of aneuploid oocytes coming from the donors was 25%. So after that, we decided to offer NGS testing or polar body testing for selected group of our donors coming from OVOGENE Egg Bank. So far, this is the unique option only from our bank. However, we understand that once a patient is deciding for oocyte donation, they expect blastocysts coming almost from every donor oocyte, and they expect donor oocyte to be as high in their quality as they may be. By offering NGS testing and checking euploid
Hello, Dr. Uliana, please let me know if you can hear me, because right now we cannot hear you. I believe that the connection is possibly lost. Please let us know, okay? Just please bear with us, okay? I will double check with Dr. Uliana. I'll be right back with you. Please stay tuned. Uliana, please let us know if you are okay. I think it's all back to normal, okay? Dr. Uliana, can
Yes.
you...
Yes, I can hear you. I'm back. I don't know,
Okay.
Something happened with the connection.
Yes, that's correct.
Do you hear me now?
Yes,
well?
now it's all good. So just go ahead. And it was like 3 minutes that you weren't here, but of course,
Okay.
Now I can hear you, so all is okay. Let's go ahead.
Okay, wonderful. So we were talking about genetic testing for the donor oocyte, which is if we are checking the euploidity of the donor oocyte, we are avoiding the fact that 25% or up to 30% of those oocytes may be aneuploid. And we understand that once patients are deciding to use donor oocytes, they would expect probably from every oocyte to get a blastocyst. And we cannot expect this if we don't do additional checks for the donor oocytes, because they are human beings and they are producing between 20 to 30% of their oocytes being aneuploid. So this specific testing will give us the opportunity and is giving us opportunity to offer patients the highest quality and the highest probability for the blastocyst creation and implantation potential for those embryos once we are offering genetic testing. So, and most programs in oocyte donation are not doing this so far, but we believe that this would be the best option for the patients. And the last thing, that in our team, we don't believe in the diagnosis called unexplained infertility, because for us, this means that generally the clinicians were not able to find the true cause of the infertility, and we should keep looking for the reason why this couple was not getting pregnant so far until now. And if we will keep looking, we will definitely find out what would be the reason, because there are many of those, and for many of the patients also this will be a multiple reason, and we need to find as many reasons and overcome them as possible in order to be successful in our IVF treatment. So to conclude, there are many different treatment options which may be recommended in IVF to achieve a goal of parenthood, including using own oocytes, including experimental treatment involving third-party reproduction, etc. Second opinion is recommended due to specific limits in the countries, and very often something what you have heard or you have read about, it is not practiced in the country where you are going to be treated, and you should just keep looking for those options somewhere else. The most effective treatment for patients in advanced maternal age right now is oocyte donation. However, there are experimental treatments available in IVF, and they are effective and may be accepted widely in the future. Genetically certified oocyte is advanced technology which is so far offered only by OVOGENE Egg Bank to increase chances of euploid blastocyst outcome and pregnancy chances for the patients. Polar body biopsy does not affect oocyte quality and morphology or survival rate during vitrification or sowing. And we also offer this technique for patients in their advanced maternal age, but specifically for those who would like to freeze their oocytes. So they are coming in their age, and by international regulations, it is not recommended to freeze oocytes for the future use if patient is over 38 years old. However, if she is even 40, but she has still potential to produce her oocytes, we can offer her to several cycles of stimulations, because more probably we would need to combine several treatment procedures and to keep together all oocytes from these several treatments. However, we would recommend her also to check genetic status of her oocyte just to understand what she can rely on in the future. Genetically tested oocyte has significantly better euploidy, blastocyst rate, and implantation outcome. Chromosomal abnormality risk dramatically decrease after the polar body and embryo NGS testing. And if you are here with us and you are listening this webinar, but you haven't tried all the mentioned above options, you should keep trying and remember the publication from Israel that more cycles you do, and if you are just not stopping, just continue your treatment, there is still a high chance for you to getting pregnant. Thank you so much. And now I will be happy to answer your question.
Thank you so much indeed. As always, it's been a brilliant presentation. This is definitely a topic that brings lots of questions. So thank you for explaining everything so thoroughly, as always, really. So it's always great to have you here, as you know. And as you can also see, there are some of the questions right here ready for you. So let's get to those questions straight away, okay? And of course, if you haven't asked your question yet, you know what to do. Just type those in the chat section. And the first question is from Margie. So how does ovarian rejuvenation work? What is the age range of patient using that method?
Yeah, thank you, because we were stopping just briefly on that procedure during my presentation. And we have a group of the patient, and we did this even also for the treatment of the patient, but it was also important for us to understand what should be the inclusion criteria and how it works for the different patient populations and different age group and different IMH groups. So I may say that initially we accept for ovarian rejuvenation technique any patient who has a desire of trying her last chance of producing her own oocytes, however, which is still cycling. Even if she is not regularly cycling, she's still cycling, and she has at least, because this is coming already from our data based on the number of the patients which we treated in our center, and the most successful were patients who at least have their IMH over 0.15 or at least 0.1. So if patient has less than 0.1 of her IMH, we may include her into the initial protocol of preparation for oocyte rejuvenation. We may try to do initial cycle of oocyte rejuvenation. Then we are checking how she is responding in terms of her FSH level, IMH level, if any of antral follicles are seen in the ovary. If there is a good reaction, prospective prognosis, so we will continue second and third. We do maximum 3 ovarian rejuvenation procedures for every patient. We do not recommend to keep more than 3. We would suggest some alternative options. However, for some patients, and I would say for this group of the patient who has their IMH over 0.1, they are reacting even after the first oocyte rejuvenation technique. and it works quite easily. So we are getting the blood of the patient, about 20 milliliters. We retrieve the blood. We prepare this blood in our facility. It takes about 1.5 hours. And then we are getting the blood centrifugated. We are getting the platinum-rich plasma, about 1 to 2 milliliters. And we inject it under the supervision of the ultrasound into the ovaries. We divide in the same amount for each ovary. Usually we do this under the general anesthesia, so the procedure is very similar how we do oocyte pickup. And then every week after the procedure, we are asking patient to check FSH, IMH, and ultrasound evaluation for the antral follicle growth. As maximum 2 months, we supervise this patient. As soon as we see that the follicle is growing, we are starting stimulation cycle. In terms of the mechanism, how this works, I explained this 200 days prior to which preantral follicles are getting into being sensitive for FSH. So by involving the platinum-rich plasma working in the cortex of the ovary, so we are helping these preantral follicles to mature faster and to be ready to receive the FSH and to be sensitive to FSH and produce higher cohort of these follicles which are potential to grow, to recruit also oocyte inside. But still we need to understand about the time frame. So we do PRP, we control patients during 2 months. If it's not, but still we have a potential, we consider injection and also checking the hormones and decide when to start stimulation. Can you hear me right? Because I see that I still have some issues with connection.
Yes, it was breaking at the very end, but I believe most of our patients were able to hear you. Okay, just let us know, of course. But actually, there is a question which you kind of answered, but if you can have a look. So how far in advance of an IVF cycle should you do ovarian rejuvenation?
So it's immediately before the cycle, because we don't know how you will react into the PRP procedure. Because some patients, if they are good prognostic patients, I would say that also depending if you are cycling, we would do PRP on the very beginning of your cycle in the early follicular stage. And then if we may see already follicles which are growing, we will start injection of FSH immediately after we have seen few follicles to grow. So we may start, for some patients, for good responders, we may start stimulation within the same cycle when we did the PRP. For some patients, it's different because they are not producing their follicles, grown follicles, which we may check under the ultrasound scan so early. So that's why for them, we do this prior in 1 or 2 months to the cycle, depend on the follicle growth.
Wonderful. Thank you so much. And as we are on this topic, I will show you next question. So is this procedure much like PRP? If not, what's the difference?
To which procedure? Like ovarian rejuvenation is the PRP. Yes, this is the same procedure.
Perfect. Thank you for the clarification to this one, of course. So it's exactly the same. PRP, ovarian rejuvenation, the same thing, right? Okay.
Yeah.
Thank you. And let's have a look, okay? Margie has added one more question. So does ubiquinol supplement help to improve mitochondria?
Again, like I've read about this and been contacted with some patients who are getting this supplement. However, there is no evidence. There is very few publications, if we would consider them being fully scientific and which we may rely on. However, like I have no proof for this.
All right. Thank you so much, Margie, for yet another question, of course, for answering. Okay, sorry, one more from Margie. So does it make a difference using frozen versus fresh eggs, and how much?
I would say that it depends on the facility you are working with for your oocyte donation or vitrified oocyte donation. As we are running the OOCYTE bank and number of oocytes being vitrified and warmed by our team is just extremely high. So our technique is absolutely great and we don't see any difference. As well as with some of our clinics to where we are supplying our biological materials. However, this is true. So meaning if the process is well established and strictly followed to the protocol, there is no difference because the survival rate of the oocytes is between 95 to 100%. But if we are talking about some centers who have very limited experience, because this is all experience with their hands of the embryologist, they need to follow strictly the timing for the oocyte vitrification and warming. So if this process is not well established, there is a slight difference, and we have a cutoff of 80% for survival rate for the vitrified oocytes, and we consider good centers those who are having over 80% survival rate, and those centers where you probably should use better fresh oocytes, which has less than 80% survival rate. So where you probably better work with the fresh materials. However, in our hands, vitrified are much better because they are immediately available. There is wide variety and there is no clinical difference.
Amazing, as always. Thank you so much indeed. And let's have a look at the next question. Okay, sorry, I'm just looking. Okay, next question is from Annie. Is it possible to do the nuclear and maternal spindle transfer for a woman who is 48? How is the rate of success and how much does it cost?
I would say that in order to certify the patient for the pronuclear or spindle transfer, this should be a patient who produces her own oocyte. And we have a cutoff that if we have at least 3 maternal oocytes, we will go for the procedure. We can get those 3 oocytes in different stimulation cycles or in one stimulation cycle. However, if we have less than 3, we really do not recommend to continue. So it's very much, I would say that for now, we had the oldest patient we had for spindle transfer was 47 years old. But we need to check patient by patient is different. So we need to get more information about your IMH, if you are cycling, what is the antral follicle count, maybe you have somewhere oocyte frozen. So it's a lot of questions which additionally we need to ask in order to confirm this. And the success rate for, again, we would divide this question into the group of patients who started preparation for mitochondrial or spindle transfer and who ended up with the treatment, because many questions, once they started the preparation, we were not able to receive their own oocytes, or the number of the quality of the oocytes were not appropriate. For example, we received oocytes, but they were not M2, and we need, of course, M2 to keep working with them. So there was a high amount of patients who willing to get maternal or spindle transfer, they were not ending up with the transfer. However, those for whom we did micro manipulations with their cells and who grown the embryos and who finally had embryo transfer, the success rate is for this population, this I would say very complicated population, was 56% for both. However, this 56% is 16 pregnancies so far. This is very small amount, and every pregnancy would increase our percentage or will decrease if this is unsuccessful. So this is a small numbers and it's better to talk about absolute numbers than about percentage. And the cost is higher, of course, than the regular oocyte donation, but I am not able to provide you the full cost. You need to contact our coordinators for this. And of course, Carolina will provide you with the email address and the contact details in order to ask this question.
Perfect. Thank you so much. And of course, I will put it in a second in the chat section. So anyone, if you would like to get in touch with Dr. Uliana, you will be able to do that. And I'm sure she'll be happy to help you out with more details. And actually, let's go ahead with the follow-up. Okay, Dr. Uliana, what is the success rate using maternal spindle transfer? And the number of live births, if you are able to provide that.
Yes, I may provide, like, the total number of live births so far is 9 from our programs, and total number of clinical pregnancies are 16. But total number of patients who started treatment, but again, we need to divide them into the good prognostic and less prognosis patients. So total number was over 40, but not all of them went through the whole process and went to the embryo transfer. So this we need to recommend. But if they were not ending up with the embryo transfer in their spindle or pronuclear transfer, so they were recommended for alternative and they still got pregnant. So we are, I would say here about cumulative pregnancy rate, starting from the inquiry of being willing having a baby and ending up with having a baby, but using different techniques.
And perfect. Thank you so much for providing this. Okay. As you can see, a comment, yeah, it is good result, a chance. True.
Absolutely. Because, like, you know, as I was showing these graphs with the evidence, so probably for the pronuclear and maternal spindle transfer, we are somewhere in very down because this is still experimental, but there is no alternative. This is the only option and there is no other. There is, and we have a lot of data. I can show you a lot of figures for different groups of the patients for for regular oocyte donation. And this is very successful, but it also comes from the huge figures from many years of experience, and even improving this, as we did with the NGS testing of the oocytes right now.
All right, thank you so much, Edith. And of course, there is a email address. If you need, you can always get in touch with Dr. Uliana right there, so she can help you with some more details as well. And let's have a look. Okay, there are like few questions left. We will be slowly finishing, so if you have anything else to add, you know what to do. And let's have a look. This is a question that we receive quite often as well. Can taking too much DHEA have a negative effect on egg quality?
Not directly on the oocyte quality. However, you know that the hormones, they have a cross communication between them. So the most important to have enough of everything. And if we are talking about advanced maternal age, so there should be enough estrogen. And estrogen, this is the very important hormone for everything, for your heart, for your bones, for your somatic status, for your skin, hair, etc., even your mind. But getting too much of androgens, they will get their place inside of your body. There is not direct harm effects. I was not reading a lot of those. However, definitely it will be disorganization between the hormones and receptors. So I would definitely not recommend to get more than 75 milligrams per day. This is the maximum recommended dosage, which is widely accepted.
All right, understood. Thank you so much indeed. And sorry, I've missed this before, but there is a follow-up to your previous answer. Let's have a look. So did you mention the first 3 tries in India are free? Correct me, please.
No, in Israel. I was talking about Israel. So this is the country where government is paying, or they have maybe they call this CASA, where it's like insurance, but from the government. So they are paid every couple until they have 3 children born in their family. They are paid for regular IVF, not for oocyte donation, of course, but for regular IVF, including medications, including all screening, IVF procedures, embryo transfers, everything.
Thank you so much for the clarification. So Israel, not India, but it's definitely, that sounds interesting. Thank you so much indeed. And I'm just waiting because, of course, that looks like that might have been our final question. So we will be finishing. However, if you have any questions that you haven't asked yet, of course, there is an option for you to get in touch with Dr. Uliana directly. But let's have a look. And if we don't have more questions, we will be finishing. But I think that already we had very nice and interesting questions. So thank you so much, everyone, for staying with us. And of course, Dr. Uliana, it's always a little bit later in Ukraine right now. So thank you so much for, again, joining us tonight, for answering all those questions. It's always great to have you. And it looks like we will be finishing. So before we finish, is there anything at all you would like to add?
Thank you so much for all our participants, for spending time with us and for getting more information. I hope it was useful for you and you will have a chance to read more, to ask more questions, and probably to use some of the recommendations. But the most important, what I would like to say, that you need to remember about time. And time is the best and the most important resource you have right now. I know that this could look a little bit complicated because of the COVID, because of many restrictions. However, if you have possibilities of your treatment being available in your country, please start this immediately. If you don't have, just consider where you need to go, what you need to do, how you need to prepare it, again, in order to start as soon as possible, because time is playing, if you are in your advanced maternal age, is playing a crucial role. If you are in your younger maternal age, please consider storing your materials for the future use, because this is something what we are losing every day, every minute, and which cannot be used anywhere, anytime in the future. So this is the most important, and thank you again so much.
Thank you so much indeed. And as you can see, there are thank yous coming up your way. I can see someone is already typing as well. And I just want to mention that, of course, this has been recorded. You will have a chance to watch this again if, of course, you would like to, or if you would like to share it with anyone. It will be available tomorrow on our website, myivfanswers.com. But also, I would like to let you know that Dr. Uliana will be back this Friday at 8 p.m. UK time. She will talk about IVF in Ukraine, so legislation, regulations on egg donation on IVF. So if you are not yet familiar with everything, join us on Friday. She'll be back, and I'm very excited to have you here as always. And I'm glad that we will have another webinar with you. And as you can see, Dr. Uliana, always thank yous coming up your way. So it's been great to have you. And again, I will be happy to see you back here tomorrow. But of course, I do hope to see you all right here on Friday with Dr. Uliana. Thank you so much, everyone. Have a relaxing evening. And as you know, we will be back tomorrow. Tomorrow, we will talk about IVF regulation, in Greece. So if this is something that also is interesting for you, come and join us. And I'll be more than happy to see you here for sure. Thank you indeed. Take care, everyone. And bye.
Thank you. Bye.